Yeah. But also, we kindly encourage everyone to, you can just write your question on chat, or you can even add in a comment there while we are proceeding. And during the discussion or question and answer time, the speakers will just respond to those questions accordingly. So please make sure that if you have, if you saw a certain question someone has added there, and you fail to respond to that, you can even write on chat. You can even respond to that question on chat. Yeah. So the webinar will run for 90 minutes, which is 1 hour and the 30 minutes. So let's be respectful of each other or opinion. Whenever you are writing your comment, your response to the question someone has addressed in the chat, please respond to it in a positive manner. Don't use the words which which is not good. Yeah. So our hashtag for today webinar will be ECSACONM webinar 2025, and that's how it will be added in the YouTube and the other social medias of the college. So please stay assured that the webinar record will be shared later in our YouTube, but also it is available in our website. When you go to the ECSACONM website and you click on the training part, you will find the page for the webinars, where you will find even the previous webinars conducted. So for today webinar, our moderator will be Dr. Oslina Tugatonazvo. And Dr. Oslina, she's a registered nurse and midwife, educator, and researcher with over 25 years of experience in midwifery and in neonatal nursing education, including extensive clinical teaching. Her expertise lies in maternal, neonatal, and child health, and she served as a research mentor in Siakula Child Health Chat program at the University of Eswatini, in partnership with the Baylor College of Medicine and the Ministry of Health. She was a senior lecturer in midwifery and in neonatal nursing. She has significantly contributed to the nursing and the midwifery education in Eswatini and across Africa. Her role includes curriculum and program development, midwifery reforms, and the sharing curriculum reviews to support accreditation. Regionally, she helped in develop training for prevention and management of obstetric fistula through the ECSA Health community, and a Sigma Global Health Leader. She has advanced the nursing scholarship, capacity building, and the quality improvement project. She is widely published, serves as a journal reviewer, and currently teaching in ECSACONM fellowship programs. So, Dr. Oslina, you're welcome to moderate our webinar for today. The floor is yours.
Thank you, Julius, for that introduction. And good afternoon to all participants and the ECSACONM Secretariat and our experts who are going to present today. Today, we appreciate you all participants for making time in your busy schedules to attend. And we encourage you to participate actively and utilize the information which you get. As participants, we would like you to participate actively in the discussions and also suggest ways or share best practices of integrating traditional and modern midwifery. Our theme today is integrating traditional and modern practices in midwifery, which is critical in our management to improve maternal health. So before I progress, I would like to give the platform to our registrar, Dr. Elizabeth Oyawa, to give us some opening remarks and guide us in this. Thank you.
Thank you so much, Dr. Oslina. Thank you everyone who has attended this webinar. I want, on behalf of ECSACONM President, to welcome all of us to this webinar. We take the webinar so seriously because they have been a very important part of our CPD programs. ECSACONM's motto, as we are all aware, is professional excellence. Professional excellence, and we do this many times through short courses, through webinars, through our fellowship programs, and through other means that we have been doing as ECSACONM. So those who are not members yet, please go to the website, read about us, and register and join ECSACONM, because ECSACONM is the place to be. The climax usually for ECSACONM are our biennial and quadrennial conferences. As you are all aware, we have a quadrennial conference next year. We are going to share with you the details about the dates, the themes, the sub-themes, and also the venue and everything else that goes with it. It will be definitely in September 2026. So diarize and be ready. So we do everything that culminates into our next year's conference, which will be a turning point in the history of ECSACONM. Since we started the fellowship program, our first cohort has finished first year. Second cohort has started first year. Second cohort are already in the clinical sites. And we are hoping that by the time we go for the next ECSACONM conference, they'll be graduating. So it will be a beautiful time to be. And I know Dr. Oslina, as one of our faculty, will be there just to see her students graduate. We want to thank you for attending. Thank you to the moderator for agreeing to be our moderator today. Thank you to our excellent speakers who are joining us, Wanga, Prof. Priscilla, and Dr. Twala. We want to really appreciate you for your time. I also want to welcome all the participants to this forum, and we are sure that it will be a worthwhile experience for you this afternoon. I've seen several colleagues from the different areas within and even outside ECSA region. Please continue coming. They are very important for CPD. And also, it gives you an opportunity to interact and learn new things in the field. With those very few remarks, I want to declare this session, webinar 2025 September, officially open. And thank you so much. Back to you, Dr. Oslina.
Thank you so much, Dr. Elizabeth, our registrar, for those words. And I believe we've taken cognizance of the importance, the significance, and the reminder about our ECSACONM quadrennial conference in 2026. We'll diarize that. Thank you so much, and thank you, the participants. And thank you for making time in your busy schedule to open this webinar. Then we do continue with our webinar objectives. Before I go there, I would like to remind you what you have been informed in the introductory. If you have a question, you can put it in the question and answer section. If we don't manage to answer your question there, please hang on. We'll answer it at the end of all the presentations. In between presentations, we have limited time. Therefore, we are going to allow 2 questions if the time permits. And for our presenters, we are happy to have you with your 15 minutes of presentation and 5 minutes. I'll only interrupt when you have done the 15 minutes so that you'll be able to summarize the presentation so that no one loses out. So our today webinar objectives is the value of traditional midwifery knowledge, which is quite important because we are going to have an overview of the traditional midwifery practices, which we all need because we work with people in communities. We are going to also have practical experiences in blended traditional and modern care. In this objective, we try to unpack some countries who have had some experiences with how to blend traditional and modern care. This will help us when we go back to our practices, our workstations. Remember our role as advocates and our role in being involved in policy development. This will be taken by Dr. Twala on building systems for sustainable integration. This deals mainly with policy, and as midwives or leaders or anyone at our point of professional level will be able to see how we can participate and improve this blended traditional and modern care. So our presenters for today, our speakers for the first topic, we have the value of traditional midwifery knowledge. We have Mrs. Zulu, who is a PhD fellow in public health at the University of Zambia and currently serves as a chief community health officer at the Ministry of Health. She's married with 3 children and is deeply committed to advancing maternal health through research that bridges traditional and modern care system. This is demonstrated through her doctoral work, women's experiences towards traditional medicine and use during childbirth. She also did exploring complex indigenous knowledge systems in Zambia, which is one of the African countries where we can also borrow from. And she investigates how indigenous practices can complement biomedical care to improve maternal outcomes. As part of her PhD output, she authored an innovative integrated maternal health toolkit, which we should all try to access, titled Rooted in Tradition, Guided by Science, Linking Tradition and Modern Care for Safer Motherhood. Mrs. Wanga is passionate about respecting and protecting indigenous knowledge, ensuring that the rights and autonomy of local communities are upheld. She strongly believes such approaches are essential for achieving equity and sustainable improvements on maternal health. So, our next speaker will be Professor Priscilla S. Dlamini. She's going to talk to us about practical experiences in blended traditional and modern care. This is a very important and interesting topic because the practical and the scientific aspects are going to be unpacked. Professor Dlamini is an associate professor and dean of the Faculty of Health Sciences at the University of Eswatini. She's a registered nurse midwife with advanced training in curationist, which means a specialty, health sciences, and education. She holds degrees from the University of Botswana and KwaZulu-Natal, South Africa. With over 3 decades of academic and clinical experience, her research focuses on HIV stigma and discrimination and chronic disease management and indigenous knowledge systems. She's an expert in that one. She has extensive expertise in qualitative and mixed methods research, as well as participatory inquiry. Professor Dlamini serves as principal investigator for the Circular TB HIV Research Training Project in collaboration with Baylor College of Medicine and the University of Texas. She has contributed significantly to stigma measurement tool development, HIV stigma studies across Africa, and health capacity building. She's a member of KEAS and Sigma Theta Tau International. She's widely published, nationally recognized, and continues to mentor imaging health researchers. Our last presenter is the youth, the upcoming, you can see with a smile, building systems for sustainable integration. That's Dr. Spiwe Twala. She has a master's in midwifery from RMIT University, Melbourne, Australia, and a PhD in public health from the University of the Witwatersrand, South Africa. She has extensive midwifery experience in midwifery practice, teaching, and research. She's an international research and policy consultant at her younger age, MVA, in sexual and reproductive health, with a focus on HIV prevention, maternal and neonatal health. She's a senior lecturer at the University of Eswatini and one of the research supervisors in the ECSACONM fellowship. So these are our presenters. She brings in the issue of policy and how we can be involved. So at this juncture, I'll call upon Mrs. Manga Zulu Mbanga to present on the value of traditional midwifery knowledge. And remember to direct your questions on the question and answer, if any, even the comments. Thank you. Over to you, Mrs. Manga.
I think we can just we can proceed with the prof.
With Prof. Okay. We can proceed with practical experiences in blending traditional and modern care in midwifery by Professor Dlamini. I think it will have technical connections we are going to have after here once she connects. Thank you. Over to you, Prof. Dlamini. Professor Dlamini, you can start because we can't get hold of Mrs. Manga. Over to you.
I started talking. Oh, sorry. Do you hear me now?
Yes, Prof. I think you were muted.
Oh my God, not when I've greeted everybody so excitedly.
We missed the greeting. If you don't mind repeating it. Thank you, Prof.
No, I was greeting everybody at ecsa-hc, the program director and everyone, professors, experts in this field. And of course, midwifery is being midwifery. All of us were here because of that. I don't know if people would like to even see my video, but I think then we'll have challenges with our internet. But just in a nutshell, the word integration means something else. And it's different from collaboration. Because when you say integration, you mean that things have to really be integrated into the modern, practices of midwifery or any healthcare system. But if you say collaboration, then that is different. People can work there and others work there, but make sure that they come together at times and collaborate. So I just wanted to kind of like maybe unpack what do you mean by traditional midwifery? It involves the holistic care, addressing all the elements, the physical, cognitive, mental, social, and spiritual. And somebody may ask, how does that differ then from the modern care of midwifery? then that one I will not answer because I think other people will be also addressing that. And then it views the birth as sacred and being a natural process utilizing ancestral wisdom, herbal remedies, and hands-on experiences. Luckily for me, my grandmother was a traditional birth attendant, but at that time, I don't think she was classified as that. What everybody knew was that she could deliver women. They would line up. But I used to see her using herbs, and she even taught me some of those herbs. Before I even went to school, I knew there were two plants. The other one, I knew where to find it and combine it with the other one when somebody was having threatening abortion. So it was more than just delivering babies. It was more concentrating on the maternal as well as the child. So you can see that it becomes more holistic. And of course, a lot of traditional methods can be applied. And these are old methods because birth, I think, started with Adam and Eve. Somebody had to really do something. Massaging the body. Sorry, I wrote message instead of massage. Herbal concoctions, prayers as well, and meditation, yoga, including advice on the family with knowledge passed from generation to generation. So I would like us to see that traditional methods, sometimes you are not trained. But what I like is that it was not just everyone that would do this. They will be able to identify the gift from as the people were born and as you were growing up, they will see the gift that this person is gifted, so can be trained and so on, can be trained on this aspect by passing the knowledge, and this knowledge tend to be orally, and it was through observations. When the elderly people were doing, the deliveries, when they were taking care of the woman. But again, what I like, which I did not, of course, capture, is that women were born to make sure that they can give birth. They can perpetuate the culture and so on. So the preparation of the woman would start from birth. When we are born, we are a girl, we are given a name that relates to a girl. And then as you are a girl, you are being groomed as well to make sure that you become a proper girl to be able to give birth to a live child, to contribute to the nation by reproducing. And that, of course, included a wide range. It was not just only herbal concoctions or whatever, but we were also prepared even in terms of diet, in terms of food, and also slowing down your reproductive kind of like a spurt. There were certain foods that were not allowed in our culture. For instance, girls were not allowed to eat eggs, to eat a lot of meat because they will grow fast and then they will become pregnant before time and then they will give birth to weak children. So everything was more about also getting married, having one man, not to have multiple men, and so on. It was mainly in preparation. And then now when you become pregnant, from the beginning, you were supposed to report that you have missed a period. Then from there, you will be told. So that's where the advice on the family, came from, and so on, even on what food to eat. For instance, in my culture, once you were pregnant, then you were not supposed to eat liver. You were not supposed to eat eggs. Otherwise, the baby would be born without hair if you eat liver. Whether that was a good practice or not a good practice, but it was part of the traditional, method of when a woman falls pregnant. and then it will go on being passed from generation to generation. And the elderly people were always looking after the families, even after birth. After birth, a goat had to be slaughtered or chickens have to be slaughtered. The woman has to get succulent, from the boiled, the broth from the broth from the meat and so on, to make sure that she makes more milk, including sour milk, including emahewu, so that she can eat and so on, thin porridge, sour thin porridge. So even the diet was traditionally prepared and so on. And then there were also the ancestral practices that can be blended with Western, but one of our ancestral, practice was that when the baby was born, the baby would be immunized. And the immunization involved what today we call the totem, that when, if you are a Dlamini, for instance, you are supposed to be immunized, and they have to add a sheep. That's why the Dlaminis even today can't eat sheep, because that's what they were immunized with from birth. So it's like you are now adding the immunization and so on just like when you take your diphtheria and so on immunization, you can't repeat it. So those were done for that. So there are so many cultural rituals that were done and so on to make sure that it's really traditional. And they had reasons for that. And the other traditional way was to make sure that if labor was slow, then herbs were used to enhance, labor. Though the unfortunate part was that sometimes they didn't know when to administer. It was more like your oxytocin and so on, but they didn't know when to administer it because they didn't know whether your cervix has already effaced or what, but sometimes the women will take it the minute labor starts, and then they will have maybe complications in labor and so on. So we will see when we come to the benefits of the integration, the exchange of information to assist correct some of the traditional practices that were detrimental to the woman. And then one has to explore first, like I said, is it collaboration or integration? How can we coexist? I used to say when I was in the labor ward that maybe if we can allow that we coexist, like we will see with some of the other countries that are trying to do the integration with the traditional and modern midwifery, we can assist a lot because the women will not hide the concoctions. They will not hide from the Western professionals. They will make sure that everything is out and they are able to talk about it. Then we can give them at the right time, like maybe if the cervix is now 8 centimeters to 9 centimeters, then we can say, oh, now you can take your concoction to hasten the second stage of labor. But because we are not able to coexist properly, and what I've noted in all the readings that I've done, and also knowing from experience, we have always needed traditional birth attendants when we teach them, but we never learn from them. We never give ourselves time to learn, to find out why are they doing what they are doing. And then we tend to kind of like say, this is wrong. You can't do this. One thing which I've also noticed is the measurements. In most cases, we think in the traditional, birth attendants, they don't have measurements, but they do because they will talk of your mouth full, your hand full, and our hands are not the same. And our mouths are not the same. But even us on the Western side, we fail to have scales where you measure milligrams per body weight or body mass. I wonder how many people have those scales to really sit down and measure to say this one we can give 5 milligrams, this one, though it's an adult, we can give 10 milligrams because we've really measured and so on. But I think it's even a better measure with the traditional birth attendants when they say the lady should take a handful or should take a mouthful because that mouth is equal to their body. So there are no chances of overdosing or underdosing. Anyway, also explore the roles of the traditional birth attendants. And we have to also really sit down and say, what are they bringing? What knowledge do they have? Why are they doing this? Because in most cases, I've seen workshops, even where we teach them how to take vital signs, how to do this, is always, I mean, one-sided. We never really explore as to what is it that they do. Then come to case studies and showing successful integration. I wouldn't actually say it's successful, but there are a lot of studies that have been done in this area. The blending of the two systems can be through proper training, thus adding principles from modern approaches to the traditional approach. But I also believe we have to also add principles from the traditional approach to the modern approach. There must be an exchange of information and practices between the traditional birth attendants and the health professionals through knowledge dialogue. Sit down with them. In one meeting of traditional healers, in fact, we were approaching the process of collaboration. So we had traditional healers, we had nurses, and we had doctors. Luckily, it's in one of our healthcare center. One of the nurses stood up and asked and say, traditional healers, you always bring clients here and you say to us, we should give them blood. They have shortage of blood. And then we'll give them tablets. And when we've given them the tablets, then you still turn them back and say, you didn't mean tablets. Luckily for us, because our healthcare centers admit patients, there was a patient with an IV drip. And one of the guys stood up and said, when we say they are having shortage of blood, we want you to give them that water. So in other words, if we don't come together to really have an exchange of what do they mean, because also in my PhD study, I realized that naming of certain aspects in health is very, very different. You can imagine here they've identified that it was dehydration, but they were naming it as lack of blood. So then it means the approach might be different, even if you try to collaborate. You have to understand each other. So also the integration has to happen in that way, understand why they are doing what they are doing. So there must be the exchange of information, including practices between these two. So this can be in topics such as family planning, both traditional and Western. When I was doing my specialization in family planning, we went to Mauritius, and I was shocked that those people were doing the traditional method of family planning so well. The man was involved even in checking the thinning of the vaginal fluids. They had even a booklet. They were properly doing it. They were having even a booklet. She knew the temperature of the woman when they can, I mean, engage to make a baby. And they knew when they can engage to make sure that there is no baby. So they were keeping, I mean, this in records, and ours was just to come and check the recording and so on. And also the whole family was involved. So in the traditional way, we also involve the family. But also in Western, I mean, cultures, the family is involved, and we're really revolving to realize that you can't deal with the woman alone. So we've learned also from the traditional ways that whenever a woman comes to give birth, the men also should be allowed. And also, even any relative, can be allowed. I know that with the dwindling finances in our countries and so on, now we are no longer affording to admit the women for a longer time to make sure that we're able to supervise them. And by the time they go home, they are able the childbirth has been kind of like a family experience and so on. So those can be the prenatal identification, warning signs. Those are some of the topics that can be covered by both and so on. And if we want the integration to be successful, childbirth and care, let us not dispute what people do, but we have to explain to them why you can't do that.
Apologies, Prof. Can you are left with 5 minutes.
Okay, thank you, dear.
And for the participants, can we block our videos, please? Let's just have the audio. Block your videos. Molini and Waheda. My apologies for that. Okay, you can continue, Prof.
Okay, so technology and traditional practice may need to be explored as well. Right now, we are having cell phones, mobile phones, and so on, and even the traditional birth attendants, in terms of the integration, can be trained to use these tabs. And of course, successful integration models often involves cultural responsiveness, community-based programs that value both, knowledge. Then we have seen a difference, in different cultures and so on, who are trying to integrate. I don't know if we do have that system in my home country. I'm yet to learn. But I know that nurses do collaborate with the traditional birth attendants and so on. But I don't have a formal thing. But I've seen that in countries like Bolivia, they have what they call family community intercultural health. And of course, in places like Australia, they have the Victorian Aborigine community controlled health organizations. And also in Mexico, they have the respective dialogue between the traditional and the health, professionals. You talk of also other countries like China, they also have systems of, integration and so on. Then we have also done a lot of, in the case studies, a lot of research that has been done to explore some qualitative research. For instance, one was exploring the integration of indigenous traditional birth attendants into the Western healthcare system. That was a qualitative, research done by Halo in 2024. And then we had the one also done in 2022, Recognize and Acknowledge Us, Views of Traditional Birth Attendants on Collaboration with Midwives for Maternal Health. And that is by Musi in 2022. So there are quite a number of research, that have been done. You can see that everybody is moving towards integration, but we need to do it, properly and so on. And I think my last thing would be the ethical approaches when matching these two systems. I'm not going to talk about the advantages and so on. Mainly, it's about cultural respect and potential conflict practices and human rights. One has to ensure autonomy and a well-informed consent, as well as prevention of harm. Eliminate the harmful practices within the cultural context, upholding justice and balancing the midwives. Autonomy and non-maleficence, equity and justice, human dignity and respect. Of course, let us be culturally sensitive. Respect diverse cultural practices while eliminating harmful practices. Integrate knowledge, advocate for women's rights, holistic and compassionate care, personal and professional growth. I think my discussion will end up there, because what we want at the end, we want to have and reduce maternal deaths as well as child mortality rates in our countries. by integrating both systems. And we need to learn from both the good practices and try to explain to each other why a certain practice is not a good one. Thank you.
Thank you, Prof. Dlamini, for the presentation and clarifying, making it very clear why there should be integration and appreciating the traditional midwifery aspect. In the interest of time, I'll just briefly summarize your presentation. And please, your last part, reserve it for our discussions, the lessons learned from community-based and hospital settings. We're going to discuss at the end. We'll need that aspect when everyone else has presented. So from this presentation, we learned about the holistic approach from the traditional birth attendants, and we learned that they don't only do deliveries. They also use a holistic approach where they look at the physical, mental, social, and spiritual aspect. And we also learned that they don't just do their work. They are going through a period of training in the family as they start observing early and they see what the elders are doing, and they also have to have their hands-on, and they've also communication with their clients. And we also learned that these are practices which run in families, which are ancestral practices. What question was raised is, what is the role? What is their role? That's what we should answer now. What is their role, which we have observed, but it's not confirmed in the modern medicine. And we learned also that there are immunizations, but these are traditional, which we need to do. So we should mainly recognize that we coexist with them. Therefore, since we coexist, we need to identify areas of education where we should also learn from them. Because for us to accept their practices, we should learn from them. And we know in modern medicine, we always want to prove. So we should be able to engage with them so that we can be able to integrate their services into the modern medicine. But as we go to the next speaker, we will also be informed of how would we integrate, because it should not be a haphazard situation, but we should always learn from them. Thank you, Prof. Dlamini. Our next speaker, I think, is Dr. Twala, because I haven't seen our first speaker. We hope by the end of her presentation she will be in. Over to you, Dr. Twala, who is going to talk about building systems for sustainable integration.
Thank you very much, Dr. Obi. I hope I am clear. Can you hear me clearly so I can shoot?
Yes, you are audible.
Thank you very much.
Thank you.
All protocol observed. Greetings to everyone in this webinar. So basically, we are just going to talk a little bit about integrating these. It's a big topic, and I'll do my best to summarize it. So what we do know, just as a quick background, that our training in the biomedical systems with formal midwifery, we do not take cognizance of local indigenous knowledge or indigenous healthcare practitioners, and we view them with suspicion rather than as partners. So unfortunately for us in the formal healthcare system, traditional birth attendants do not disappear. They continue to function whilst we also function in the biomedical system. So it becomes a parallel process. And whenever we are forced to acknowledge them, we tend to want to assimilate them to be part. I think it goes back to what Prof. Dlamini was saying, that is it collaboration or it is integration. And there's a tendency to minimize their role and regarding them as largely unsafe because I don't think they are well understood. Next slide, please. So in the end, what we then have is traditional birth attendants have a huge clientele. They enjoy the trust of our communities. So people will see them. There is a demand for their service. So we tend to see women late, women and the newborn late when complications that could have been avoided or easily treatable have certain and they've reached irreversible stages. So basically, these women and their babies come to die with us. And because of that, the people that suffer the most are the clients, the women themselves, because they don't tell us enough information. As Dr. Dlamini said, they tend to hide information. They will not tell you that I saw so and so in the community, and this is what I was given. So because we do not have enough information, inadequate assessment or maybe even misdiagnosis is quite common. We see after the effects that no, there was something else that was going on here, but the client will have kept this information because they are afraid of responses from us. Next slide. So it's important to note for integration purposes that TBAs and midwives have different sets of skills. These can be complementary. One does not erase the other. And that traditional birth attendants and midwives have a common goal. For the purposes of this presentation, midwives mean those that are formally trained in midwifery using the biomedical means in the formal healthcare system. So both these people want good perinatal outcomes. Also, it's worth considering that TBAs, because of their training, the nature of their training, that is quite different from formal training in biomedical practices, tend to be more culturally sensitive to the populations in which they are inherent in or they exist in. Midwives tend to be more scientific, which is objective and structured, and those means may not be cognizant of folklore and cultural realities of communities, so which results in insensitivity. Not because they are cold people, but it's just the approaches in training. So when we do the frameworks, then it's important to note that policy never starts from a blank slate. There's always something going on because policy tends to come when we are trying to solve a problem or address a situation. Like right now, with integration, we want it to be formally structured, but because we've been living in communities with TBAs, whether we were recognizing them or not, they have been in existence. So there's something that people are already doing, be they formal midwives or traditional birth attendants themselves and the clients to cope with the situation. So when we do this integration, we must realize that we have to consider that if we want the policy to work, if we want it to succeed in implementation, these means must be recognized and there must be a way to integrate them or agree consensus to say, okay, this is what we were doing, but for now, let's put this aside and you collectively chart a way forward. So policy integration processes will not be linear. When there is no policy, ideally, you want to say, okay, let's formulate a policy first, but then people will be doing things before the policy. So sometimes something is being implemented and developed at the same time. That is also important to realize so that we don't get lost in the process. Next slide. So while we do, we should remember that we have to, when we do the integration process, we have to set the agenda, what gets into the policy, then the actual content of the policy, think of implementation strategies and who does it and how we measure that strategy so that we can evaluate. So already in our existence, we have some policies that present opportunities for integration with TBAs. One of them is male involvement. Male involvement is what we have come up with. I think there is a global consensus that reproductive health doesn't work very well if we leave out the male partners, Now, fortunately or unfortunately for us, to implement this policy, we need it to be an acceptable thing by the males that we are hoping to involve. And in many cultures, including Asia and Africa, men culturally have minimal involvement in some of these things. Some of these things are considered women's business. So if you want to involve a father or a husband in a labor or in the labor room, it is considered taboo. So we might have the policy, but to actually get the men to come might not be possible. It's the same thing with contraception. Men tend not to be actively involved. It's considered something, it's women's business, but then the women can't really do it without the support from partners and their families. So for us to implement this, this is where we really need traditional birth attendants, because they understand our societies much, much better, and they can broker this relationship. So if we include them and we integrate them in our family planning practices, when we communicate these messages to women up to when we now give it, we will know they can help advise us what can be culturally acceptable for a man and what can then not be done, So that's a good example. One other way in which you can integrate their involvement is in these policies. Another one is pre-service curriculum. In our teaching, we can integrate traditional birth attendants in all aspects of childbirth, right from preconception right up to the postpartum care. And this should go beyond just maybe asking traditional birth attendants to refer women and clients and families as we do currently, but we can explore where we can literally partner with them so that they are part and parcel of what we do every day. Be it preconceptually to advise women and to encourage them. And this also includes knowledge sharing, as Professor Dlamini put it. Next slide, please. Another one is primary healthcare policies, which are also global, and this includes Africa. This is a really good opportunity to include TBAs, and in fact, they can be a good arm of community midwifery, because they are inherent in communities. So if we formalize that process, currently in many countries, and I know in my country, when the drive by WHO and partners towards skilled birth attendants was in place, there was a move within local context to erase traditional birth attendants. It was almost like an embarrassment for a country to say we have TBAs. So we rebranded them and called them community health workers or rural health motivators in some instances. But the reality on the ground is, in many of our settings, we were in some places as much as over 50% of the babies were being born outside hospitals and were seen by traditional birth attendants. So we tried to hide those statistics. But maybe this is an opportunity not to try and erase them, but to involve them and to make their role clear so that we can see where do they start and end, where do we start and end as midwives, and then the referral processes should also be clear when we need to involve other specialties like obstetricians and the like. We also have domiciliary midwifery, where we now follow somebody outside after they've given birth in the community. This is one place where the traditional birth attendants can help us, because we know that in countries, our governments don't have enough funds for community outreach clinics, for us to go and see clients. At the same time, our clients tend to live far or often have challenges paying for transport to come. And we do also know that culturally, in many societies, a woman and her baby should not come outside of the family or even the house for a full month, which is why we then need the home care. But we don't have enough numbers of the formally trained midwives because of the shortage in skills in countries, and also resource constraints in doing outreaches versus being centrally in a clinic. So we can, and this is already working in many countries. In Mozambique, for example, I know that there was a drive to introduce misoprostol to manage postpartum hemorrhage, and this drug was to be given by traditional birth attendants. It was tried, and it's not just Mozambique, even in other countries. In Eswatini, we already do it, but we say they should help refer women to the facility. So we can formalize that role more and give them a more active role. In some places, and I know that in Australia, they have something they call doulas. It's not the only setting, in other countries as well. So this is basically somebody like a traditional birth attendant, a lay woman. It is not necessarily a relative of the woman giving birth, but it's somebody that will offer support who is integrated into the formal healthcare system. So they are allowed to come into the labor ward and they are with the woman the whole time. You know, they help her with cope with the pain, breathe, will hold their hands, will walk around, because those societies or formal health systems recognize that women during childbirth tend to want to have somebody that they are familiar with to assist them and walk them through this emotional and important childbearing experience. And so those governments have found a way to integrate this person within the formal healthcare system. This person will not replace the midwife. The midwife will still be there. The midwife will still do the monitoring that they are supposed to do, including communication and being with the woman as well. But they will do it in partnership with the doula. So this is another example where such an integration can be done. But even then, it tends to be only in certain places, such as in this case, in the labor ward. But you don't see the presence of the TBA in the other aspects of childbearing, such as preconception and antenatal care or postpartum care. Another one would be, for example, shared care. You can have, there are many models of midwifery care. So we can include the role of a traditional birth attendant, the same way we have midwifery-led care, who shares that care with an obstetrician, such that, for example, in certain times of the pregnancy, maybe 16 weeks, the woman takes a scan, a routine scan, and they may go to an obstetrician's office or something, but then return to the midwife for care until certain designated times. So we could do something similar and involve a TBA. So in some instances, the midwife, this woman can be seen by the midwife, and this would be for low-risk women, of course, and it would also mean training them should they see signs, elementary signs of something that they are not sure of, you know, and in the communication. It doesn't mean the midwife is replaced, but it simply means that the team is enriched. I think I'll just leave it there in simple terms for now, because we don't have enough time to maybe break this down further. Next slide, please. We can also transform, and it's another opportunity, transform our maternity units into birth centers. We already have birth centers. We've seen them around the world. They are quite common in the developed world, like Netherlands, UK, Australia. And I know that in South Africa, they have them now. So what a birth center is basically it is like almost like a house. It's something that looks like a house. It has a home field. There's a living room with couches and TV and little kitchenettes where someone can make a meal, even hit something. And then there's a room in which the woman can be in, who's in labor. They can be with their partner if they want. So the bed is big enough and they will have the midwife there. But it is quite close to a hospital. In case there is a sudden complication, you can just wheel them directly to the hospital for theater or whatever else that is needed. So in those centers, you can also include a traditional birth attendant, and they can be part of it. The idea is to have the woman be in a home-like situation. It almost feels like a home birth. If they want a water birth, there are facilities for giving birth in water. The midwives are trained. They can be with the traditional birth attendant as well. So it doesn't have to be done in exactly that way. It can be done in a culturally sensitive or inclusive way, but it is an example of a policy where this can be introduced. And you can already see that there is quite good opportunity to include TBAs preconceptually in our policies, antenatally, perinatally, and postpartum. I think you can move on to the next slide, please. Okay.
We have 5 minutes.
I'm almost done. Thank you.
you.
Thank you very much. So opportunities that we have for including them, other than the policies I've already just said, is that TBAs are generally welcoming and willing to be part of the formal healthcare system. We've seen this, such as when Prof. Dlamini was saying that we train them. We have trained them when we were forced to reckon with them. You know, of course, we ignored the knowledge that they already had, but they were quite willing, and they were willing to adapt and adopt our modern methods. They have a wealth of knowledge and experience that we can tap from, and they have a deep and intimate knowledge of the population base or the clientele in which we are seeking to serve. They know traditional plants and medicines in use. Some of them are like the oxytocin that we often run out of at the moment in our countries. When we're out of oxytocin, it's an outcry and we don't know what to do. Whereas maybe there are some herbs that we could be using meantime to control postpartum hemorrhage. And they enjoy, these TBAs, a very strong, trustful and respectful relationships with local communities that we could also tap on and be part of the system. And I think we would enjoy an even greater trusting relationship if they saw that we embrace the people that they trust. They trusted who have given birth to their mothers, their aunts, grandparents, and even great-grandparents sometimes. Next slide, and I think it's the last. Next slide, please. So in conclusion, another opportunity is that women tend to consult TBAs before coming to the formal healthcare system. So it's an opportunity to introduce important interventions early if we have that partnership. As said already, they can be potentially a strong arm of community midwifery. And bearing in mind that most of our populations in Africa are rural, most people live in the rural area. Yes, our urban centers have huge populations, but still the majority is within the rural areas. And we do have a real scarcity of numbers, informally trained midwives versus the population demand. So this can be an extension, and they can help us maybe meet up that demand a little bit better than we are at the moment. Thank you very much. Over to you, Dr. Obi.
Thank you so much, Dr. Twala. You have summarized it very well. And from the presentations which have gone so far, from Prof. Dlamini and Prof. Twala and Dr. Twala, we have noticed that we do have non-formalized and non-regulated traditional midwifery in existence. That is a fact we cannot run away from. And the other fact which is critical is these people command a lot of respect, at times usually better than from the midwives from modern medicine. So with that and the practices which they do in communities, it is actually imperative that we, as midwives and nurses, and we may have medical people in there, health workers, we need to look seriously into how this can be integrated in Africa. This is a general observation in Africa. Some countries have gone on to integrate them, but in their different models. So we need to look at this indigenous knowledge, which is, some of it has been published, some of it is unpublished, and see how we can participate. We've seen that it plays a critical role as people still believe their cultures that we cannot take away from them, and they have confidence in the traditional midwifery. So to increase access and mainly to reduce the high maternal and neonatal mortality, integration of traditional midwives is necessary. However, this should be considered based on the needs of each country and the structures of the different countries. The two speakers emphasized the issue of culture and how we get some limitations, particularly with our cultural standing, where male involvement is required. So we should look at that. So we have also noted that there's need for developing relevant policies and models of care and operation. Procedures is key to successful integration, including orientation and training of TBAs on the agreed scope of practice. This is also very important. So we also learned that the implementation plan, from the development to the implementation plan, it should also involve the relevant people and we should be able to have key evaluation frameworks to monitor the progress. What we have noted is the midwife and neonatal nurses remain the key central entry points for initiation of relevant policies through their advocacy roles. This calls for a responsive curriculum, and we have actually, Dr. Twala highlighted the pre-service curriculum, which she also recommended that for all the courses, not only for community midwifery, should we also talk about that. So we should also be able to develop a program to develop the capacity of current practicing nurses and midwives to be able to work with traditional birth attendants, even in the absence of policy, while you are working for policy. Prof. Dlamini gave a good example where a midwife did dialogue with the traditional people and the traditional birth attendants. That dialogue is important because they feel they are recognized. So through such dialogues, you can also pass on the information to them so that they'll be able to actually improve their practices and be free to come to you to share their experiences, including the participants, the patients themselves. So because of this trust and respect from local populations, as midwives, we also need to identify the influential people and structures in our communities so that we can discuss how we can engage the relevant the relevant stakeholders for policy within countries who can be involved in policy formulation, implementation, and evaluation. Therefore, our role from here, our take-up home message could be actually to reflect back in your community and see how you can tap on the TBS knowledge on traditional medicine. Like there's someone has written in the messages that the issue of managing PPH, it was very interesting. But the question was, what is the dosage? Then some also have put on to share that one of their roles when they were working in certain programs for better health outcomes through mentoring and assessment was the quality improvement teams was to work with TBS as referral agents of pregnant women to health facilities. This model has been used in a number of countries where you educate them that they can manage these women, but they should always be referring. When they come to them, they refer them to the hospitals. They don't refuse to look after them. They look after them, provide care, but at the end of that, they refer. So they serve as referral agents and they will be quite happy. And we've also seen their various roles. So each individual, as we go back, we can look at it and say, how can we improve? So now I'll open the room to questions. Thank you so much, Prof. Dlamini and Dr. Twala, for taking time to prepare these presentations and to share with us, including your experiences with your vast experience of regional and international maternal and child health care and research. So this is a time for questions. Can we please have some questions? Or anyone wants to say anything? You can show by raise of hands, or you can come and talk.
I'm seeing a question on the prevention of PPH using traditional medicine. If I may I?
Thank you. You can tackle it if you can. Thank you, Dr. Twala.
So from the comments, one says the issue of traditional medicine to prevent PPH, Charlotte 2. The first one says, oh boy, what have I done? It is very interesting. What about the dosage to you, the use of traditional medicine? TBA's knowledge of traditional medicine like PPH is very interesting, is a very interesting area. Just thinking of the dosage. Yes, this is the thing. Well, I think the mistake that we've done all along is to try and ignore traditional medicine and TBAs and wish them away. But they have not stopped practicing and they're using these medicines. So I think probably the approach would be to engage with them and ask what it is that they are using so that we can even do some taxonomy studies to understand what herbs these are and what is the strength, and also talk to them about the dosing as well. And we can discuss with them best practices to say that hey, maybe if someone is at the start of labor, maybe don't give because then it tends to push the labor very fast before someone is ready to deliver. This is why we are losing some of our women, or maybe this is too much and we are ending up with things like uterine rupture. So it's true. And I think another one on misoprostol. I think there was a protocol even by WHO to say for TBAs how much misoprostol were they allowed to give. And they were not allowed to give beyond whatever. And there were clear referral structures to say, if somebody is like this, you give this and then do what? It wasn't just them managing the PPH with misoprostol in isolation at home. Thank you. I hope it suffices.
Thank you so much, Dr. Twala. I also share an experience of PPH, management of PPH by these traditional birth attendants. That was some time when I was actually training as a midwife, which is almost more than 20 years ago. And when I was a student midwife, there were a lot of traditional birth attendants in my country, in Zimbabwe. And what happened is we had one traditional birth attendant. Once she sends, the patient would almost be in a collapsed state. And even if you do a cesarean section, the patient may not survive because of the limited resources. So they engaged these traditional birth attendants and they developed a program where they trained them to say what can they do antenatally. But when it came to labor, any person who came into labor, they were supposed to immediately transfer to the hospital or even call an ambulance. They were empowered in that way. And they were actually, the policy developed was to stop them from delivering any mother unless the mother comes with the head on the perineum. So that actually worked. And these mothers were being referred now and they were not delivering. But this one on PPH, this woman came, she delivered. She didn't even have a drop of blood. And we asked her, and she said there's a concoction which she took, which was told that if she doesn't want to bleed much, she takes it at the onset of labor. And she had taken it, but she could not disclose what it is. But she didn't bleed at all. So those are the people whom you would want to reach out to and try to work with them. Remember, with pharmacists who also do research, because we cannot shut out these people. And at the same time, we need to avoid looking at the negatives, but also look at the positives. Thank you. Then there's a comment to say in Kenya.
I can see the hand from Dr.
Oh, yes, Prof. Dr. Mwamba.
Yeah, well, yes, Upe Mwamba.
Dr. Mwamba, can you?
Yes, thank you very much for giving me the opportunity. So this is an area of interest for me as somebody who saw issues pertaining to traditional birth attendants and attending to women. So I think we need to be very, very careful in Africa if we are to advocate for traditional birth attendants and giving them the drug for PPH. I was listening to that, I'm like, my heart was just in tachycardia because I can't just expect to give any drug to somebody who does not know the mechanism of action. And even if we teach them, those are women that have been in the community and we know they are respected, but it's very important to set limits. And we know in Africa, once we allow TBS to be like we give them that leeway of being with women and doing everything, they'll end up being the ones helping women in labor. And the biggest issue comes in when a woman dies. So even as we talk about integrating them, we need to be very, very cautious about this because things happen. In that project where I worked in, we were quality improvement. Like for me, I was the quality improvement nurse midwife for health facilities around Lusaka Rural, Chongwe, Rufunsa, Luangwa, like that. And so we moved between health facilities. It's very, very disheartening to witness a death when a TBA is conducting a birth. So let's just draw a line. And I think what we should advocate for is for them to be referral agents, like what we are doing with the Center for Infectious Disease Research in Zambia, where we were giving them stipend each time that
We are
they
losing
refer
you, Dr.
somebody.
Mamba.
And women in the communities would entrust them with information, telling them
We are
about the
losing you,
time that,
Dr.
like,
Mamba.
whenever they miss their period and so on and so forth. So it's integrating them to that level, but otherwise going further beyond that. And I think Africa, just like many other countries like Zambia, we have a lot of unemployed midwives. So let's assimilate what we have. Let's advocate for that employment. And then if we were to bring in dollars, there has to be standards. As long as standards won't be set, those same people that will be calling traditional birth attendants will be the ones that will be helping women in labor. And if there are complications, there was a time when I was working at one health facility and we found a woman who had a postpartum hemorrhage. The traditional birth attendants were the ones that were attended to that woman. Luckily, it was at a health facility. And so the woman was bleeding, like the way postpartum hemorrhage bleeds. Blood was coming out like a tap. They were busy wiping the woman, just wiping the blood because they can't understand that. So we need to be very careful as we push in the agenda. And for the issue of syntocinon, like traditional medicines, as long as we won't have the medicinal content of those drugs, let's not promote them because we'll end up losing a lot of women from that because we've seen what African syntocinon do to women. They'll start taking them whilst their dilatation is at zero, before they even start advancing in labor. And so they'll start having those contractions when the way is not open. And so most of the time that leads to postpartum, to uterine rupture because they will be having those contractions, but the baby cannot come out. So if we're not going to, what we need to do now is to spearhead research to find out what medicinal content, like that former classmate of mine from the University of Cape Town, who was looking at the medicinal content of elephant dung, because pregnant women use it. They take few cups before going into labor because there's that a traditional information that has been passed that it helps with the dilatation of birth canal, and so that prevents episiotomies. So that is what we need to be focusing on, promoting medicine, people taking those traditional herbs without any investigations on their medicinal component. I think I wouldn't promote that. So research is what we need. Working with pharmacists, we do have pharmacists who are interested in those topics because we've seen it and it can happen. Thank you.
Thank you, Dr. Mamba. I think the take-home message here is very clear, even from their presenters. The presenters talked about policy and they talked about training. So what Dr. Mamba has echoed is what they've echoed to say we don't just go there blindly, give. There should be evidence and there should be the scope of practice which is agreeable in the country. For example, I'm seeing your hand, Nyiriesha, I'll call upon you just. For example, in the messages, there's someone from Kenya who says the TBS are only considered as birth champions to the expectant mother. They encourage skilled birth attendants by trained midwives in health facilities, which means they've engaged them, they've recognized them, but they've given them a specific task, which is preventive. Therefore, they are not going to do interventions which are going to harm the mothers. This is why we are saying, how do we integrate? And that's why I mentioned about advocates and identifying the relevant stakeholders, which means as a midwife, you identify, you take it to the relevant according to your the seniority and the level of communication, so that the country will come up with a policy and a training program for them and a scope of practice for them, which is preventive. Then I will call upon Nyirishire. My apologies about pronouncing your name. I can see your hand up. Nyirishema, the floor is yours. Please unmute and talk. I can't unmute you from this side.
Hello.
Yes, go ahead.
Okay,
Thank you.
I'm Nyirishema Eve from Rwanda. And now what I want to emphasize on is to to establish the policy that can guide all those traditional birth attendants, and also to give their practice level, or to establish their scope of practice. So on my experience, sometimes the use of traditional medicines, especially in Rwanda, they used those traditional medicines in the manner that they are not clearly understood, because sometimes they give the traditional medication to the mothers who are already on labor, and it is somehow not acceptable by the rules in our country. And if they used some medications that contain oxytocin, sometimes it causes different problems like uterine rupture and so on. And and I found that it is a gap, because sometimes we know that different herbs contain different medicines, or different quality of medicines. So what I want to advise is that there is a need for research to work on those different herbs that contain oxytocin medicines, so that we can know that these herbs maybe contain oxytocins, and also we have to know those traditional practitioners, self-practitioners want to know is that to know the exact quantity of oxytocins they may provide to the mother in order to prevent all those kind of complications to the mother. Yeah, that's all about my idea.
Thank you so much for that contribution. Anyone else with a question or comment? We have 5 minutes left. Prof. P.S. Lamini, are you still there? Prof. Lamini? I think she's left. I just wanted to highlight one thing. Oh, you're still there?
Yes, dear.
Thank you, Prof. In 1 minute, please share, because I'm realizing there's a concern, which we have always had a concern since before I became a midwife, which is the dangers of these people when they are working. But we are saying we need this indigenous knowledge, and we need research. We need to integrate them. Can we just summarize how we can do that without shunning them out completely, because they are there and they are working? Thank you.
Thank you, Oslina. It's not about even shunning them. It's about the fact that they are there and you can't do anything. They are traditional, they are indigenous, and they live amongst the community. So the community trusted them, so much. Sometimes you try. Being also a fully fledged traditional health practitioner, even when you try to say, can you go to the hospital? There's something that you need to do. You can't just, when they're already in the yard, and just say, oh no, I'm referring you to go to the hospital. So there is no way that we're going to shun them. They are part and parcel of our African heritage. In fact, if you think of heritage, we've been talking about this at UNESCO. So traditional medicine, traditional health practitioners, they will forever be there because they are also born spiritual. The only thing that we have to do, because for sure, there are certain practices that are dangerous. We have to find those without saying, this is a danger, you can't do this, because the minute you say that, you have to bring in an alternative. I always say to people, don't tell me a problem without thinking of a solution. So the minute you say that, then show them that you do have an alternative to this, what you think might be a problem. And also tell them in the right way. Use your own language. They will listen. Use your own culture. Also think of the ethics behind. Respect is very, very important. Doing no harm, making sure if they have to sign any documents, you have really informed them. So that they sign with knowledge. Bring in the other aspects and so on, because there's a lot that goes on. We talk of yoga, we talk of massage of the tummy to stimulate labor and so on. We talk of herbs, but some of these herbs can be very, very, dangerous. I remember when I was a midwife, somebody came in with having used mercury, and the contractions were haywire. They nearly had, a uterine burst because of the way this goes. But luckily, she admitted that a certain guy gave her mercury. Who would really think of mercury that you can use to enhance labor? And it was all wrong. So you have to go to the community, teach those people if you want them not to use the mercury. So teaching them, working with them, bring them in workshops where you even say, today we're sitting down, come and tell us about all your practices that you do. We appreciate your work. Explain to us what exactly you did. But sometimes go in disguised. I noticed when I was doing my study where I was looking at those that were using only traditional medicine to reduce hypertension.
Prof,
I
I'm
went
reminded
in.
that our time is over.
Yes,
I'm
okay,
reminded.
dear.
Yes.
But because I didn't go there as a nurse, I just went there to find out how was the care in the hospital. Then they will explain, I'm here to measure my diabetes, but I'm not taking the medication because Mr. So-and-so has given me a concoction. So we can also do that. Thank you, Roslina. Hope I've answered you.
Okay, thank you so much. Thank you, Prof. Our time is over, but what we should remember is that we are the policy initiators. So we need to go back and see what we can
13.5
initiate.
minutes.
There's a lot of literature on this, on the, so we can do that. So our time is up. Thank you so much for participating actively and sharing your experiences. Now I will hand over to the ECSACON Secretariat. Julius will take over. Thank you so much, and go and utilize the work, the information.
Thank you so much, Dr. Oslina, and all speakers as well as participants for this webinar. I just want to take you through the website. If you go through the ECSACOM website, you can just click on the training page. If you take your cursor to the training page, you will find the specific page for the webinar series, the ECSACOM webinar series. So if you open the ECSACOM webinar series, you will find the schedule for the coming webinars over here, which is a page from the IECO. Anyone who goes to IECO, you normally get this window. So you can see upcoming sessions over here, like for the October, we have emergency and critical care nursing, saving lives in the golden hour. But also we have addressing gender-based violence for November 28th, which is Friday, and also the last for this year will be ethical dilemma in nursing and midwifery, making the right decision, which will be the first week of December, the 12th Friday of December. So the area which I want to insist is part of the previous webinar. You can find the records and you can go through. But also in case that you are interested to participate as the speaker for any of the coming webinars here, either that one of October, November, or December, please just scroll down and you will find the Google form over here. So you just have to click to fill the Google form. Yeah. So after filling the Google form, we'll keep in touch with you to make arrangement as a speaker. Either it's not only about to be a speaker, even if you want to be a moderator, you can find here the role in the session, either moderator, panelist as a speaker, or any of above. And thereafter, please, you just indicate your area of expertise and the webinar which you are referring to. So from there, we'll just communicate with you. But at the time you're filling this form, please make sure to upload the high resolution photo and also add your bio with almost 1,000 characters. So please add it over there, and thereafter we'll just communicate with you to organize for the coming webinar. Saying that, we appreciate your participations. I have been checking the track. I saw the participants was increasing from 42, almost 47, something of that kind. So there was not a lot of drop down in this webinar, which shows that the topic was so interesting. We'll just share the certificates to the panelists and the participants as well, those who attended for over 60 minutes. So thank you so much and wish you a nice day. Bye-bye.
Bye.
Thank you very much. Bye, Julius.
Bye.
Bye.
Bye-bye. Bye-bye. Thank you very much.
Bye. Bye,
Thank
everyone.
you. Bye.
Bye-bye. Thanks, Julius.